So the COMPLETE study is a multinational, multi-centre comparative trial, which essentially is used to assess the difference between culprit-only PCI following successful management of STEMI against a complete revascularisation of all suitable lesions. The study design is essentially that patients who have a successful PCI for STEMI are then randomised to a strategy of either complete revascularisation or culprit-only PCI. And one of the important aspects of this trial is at the point of randomisation, the operator had to state whether they were going to undertake a further procedure to a non-culprit vessel. And the definition of a non-culprit lesion is an angiographic stenosis of over 70%, or a more modest lesion associated with a low FFR assessment. And the operator had to state whether they were going to undertake that procedure on the same admission or undertake it in a time course following their procedure after discharge up to a maximum of 45 days. So the trial design is really looking to see if there's a difference between complete revascularisation and culprit lesion only. And it was powered particularly to look for more hard endpoints, so those of cardiovascular death, myocardial infarction, as well as ischemia-driven revascularisation, which is a new feature because of the size of the trial, which will enable us to answer some questions which previous trials haven't been able to answer totally. So the key outcomes of the trial were that, firstly, at a median follow-up of 3 years, there was a consistently demonstrated 26% reduction in cardiovascular death and MI endpoint, a combined what's called co-primary endpoint for the complete revascularisation group compared to culprit-only PCI. When you look at a second co-primary endpoint, which adds in ischemia-driven revascularisation, there's a 49% risk reduction in that group, and this is consistent out to the follow-up of median 3 years, but also right out to 5 years in smaller numbers of patients. So a very clear difference between the two treatment groups. The limitations with COMPLETE, it actually answered a lot of the limitations of previous trials, to be honest. So essentially it was a larger trial of over 4,000 patients. It was appropriately randomised. It did seek to answer whether there was a difference between undertaking revascularisation during admission or following discharge. And really, because this wasn't a specifically randomised part of the trial, it was more operator choice. It was subject to confounding factors. So whilst this trial does help answer the question around reducing cardiovascular death or MI, it actually doesn't tell us when we should be performing the second procedure on the basis of this. So the statement that it's actually safer or just as safe to undertake PCI in the weeks following the index PCI for STEMI, that question really isn't answered in this trial, even though the trial sort of states that there is no difference between either approach. I think the other thing that is important to note about the COMPLETE trial is that a large part of the outcome is driven by ischemia-driven revascularisation and MI, which was obvious in other trials. And there actually, some would argue that it's a concern that there actually, when you look at the endpoint alone of cardiovascular death, there's no difference between the groups, and also there's no difference in all-cause mortality between the two groups. The additional timing issues around the timing of the procedure. So essentially this was whether the procedure is undertaken during the admission or whether the non-culprit lesion procedure is undertaken in a time course after the procedure. What the data demonstrated is that it would seem to be safe, that you could actually defer a procedure to a further admission a few weeks down the line, a mean of 23 days, or a median, sorry, of 23 days down the line. And it's still safe and still confers similar outcomes out to 4 or 5 years. However, this was a non-randomised aspect of the trial, so we still really don't know the answer as to whether we can keep these patients waiting for a procedure or whether they need to be done on the same admission. In terms of the OCT sub-study, this was a very observational study, and basically they looked at about 93 patients all with the patients in the complete revascularization group, and they carried out OCT before successful PCI was undertaken. And what this trial, simply in an observational way, is showing is that we are demonstrating that about 40% of significant lesions have what's called a thin cap fibroadenoma, which is a marker of high risk, a high risk type of lesion. So it just helps postulate that actually some of the benefits we're seeing from the complete trial are that we're actually reducing inflammation, or we are pacifying a severe lesion with a stent and reducing the risk of further events as a result of that. But it is very observational. It's more hypothesis generating than anything else. And I think a lot more work needs to be done to examine that side of things before we can make firm conclusions about the role of inflammation in this outcome data. So the complete trial, with the data that's been produced, tells us a couple of things. The first thing it tells us is that there's definite indication that complete revascularization improves outcomes. We may criticise the endpoints to a degree, but it gives more data in an appropriately powered trial that we can reduce endpoints of cardiovascular mortality and MI. So it gives us confidence that we actually are benefiting patients and may not necessarily need to investigate them for ischemia or treat them medically as we conventionally do. It doesn't answer the question as to when we should do the procedure, whether we should do it on the same admission or after discharge. But I think most importantly, it's telling us that complete revascularization would seem to be safe over and above complete culprit lesion PCI. Even though more procedures are done, there doesn't appear to be a signal that we are subjecting the patient to greater risk by undertaking further procedures. The first question that remains unanswered is the idea of the timing of when we should do the non-culprit PCI. Should it be same admission? Should it be in a time frame following? And I think that needs a randomised study looking at that area specifically. The second issue is we obviously carry out physiological assessment of coronary lesions with fractional flow reserve. And what is the role of fractional flow reserve in assessing modest and even severe lesions angiographically? And does the use of FFR influence the amount of revascularization that we undertake, and would it influence the outcome of complete? And the final thing is that the OCT data suggests that there may be an inflammatory role that is actually driving the reduction in events that is seen consistently out to median of 3 years, but out to 5 years. And it might be that more explanation of whether there's an inflammatory element to treating these non-culprit lesions that actually is having an influence on the overall outcome, and or assessing the size of that influence overall.